has a round or oval bleb that's well delineated. It's usually transparent early on, at least. White deposits can happen in it, especially if it's been there or going on for some time. And sometimes it is associated with a little bit of cystoid macular edema. You can have CSCR with on top of it some CME. That doesn't mean it's macular edema to start with. It means that the subretinal fluid has caused some intraretinal fluid. How does this present? On a fluorescein, very easy. You can either see, and you will see an RPE leak, which can be in two patterns. It generally starts at the hyperfluorescent dot right there, and this progressively leaks, becomes more fuzzy, becomes larger, as we can see here, with pooling in the subretinal space. So this part here fuzzes out as it gives the, it leaks the fluid that's now stained with fluorescein, and the fluorescein is going to accumulate slowly into the subretinal bleb, and you can see here the outlines of the subretinal bleb. This is a very beautiful example of pooling. Now, you could have one leaking point, mostly, but a lot of people have also more than one leaking point. Now, there are two types of leaks, which you all know, either an ink blot, which is a tiny point that increases in size and remains relatively round, or a smokestack, which is less common, but very, very peculiar, in which the fluid tends to go upwards, and then it fans out like an umbrella coming down, pooling into the subretinal fluid. Okay, and the point of leakage can be really central, can be very close to the foveal center. For instance, here you have a juxtafoveal hotspot that has increased. We've seen this one before when pooling with neurosensory retinal detachment under the center of the fovea. This is, where the fluid is coming out from, from the RPE through the RPE and pooling under the retina. Or it can happen, you can have the pool in the macula, but from a source that is outside the macula. For instance, this case. This is a patient who's had a little hot spot here. As you can see, it is increasing, and it's bringing the fluid down through a track, and it's pooling into the inferior retinal space. But the culprit is the point up here. So remember that. Now, you can also have, in addition or independent of a neurosensory retinal detachment, you can have a pigment epithelial detachment. In this case, this is a pigment epithelial detachment. You recognize that the RPE layer is elevated, and the ellipsoid zone is elevated with it. And here the pigment epithelium is right there. This detachment is right there under the larger neurosensory retinal detachment. So these will also translate as little blebs. You can see them clinically as these round, bleb with a yellow rim. They could be small than a disc area or bigger, and they can be alone, okay, or such as in this case, or under the neurosensory retinal detachment. So it can be a combination. They can even leak from on top of the pigment epithelial detachment. We've seen a case yesterday in the retinal imaging conference. Now, how does a PED look? Very, very different. The pooling happens in a very circumscribed space, so you will have early hyperfluorescence that increases in intensity throughout the angiogram, but it does not increase in size because of the circumscription of the space. Now, CSR can also manifest itself as just yellow dots, subretinal precipitates, signaling that there has been fluid in the past. This is very common in chronic recurrent disease. It can be associated with cloudy subretinal fluid, and it can be associated with this, what we call a fibrin in the subretinal fluid. That is also a sign of CSCR. You can also not have a patient that comes to you acutely because of symptom, but something has happened in the past, and you know it is CSCR because you can see these multifocal RPE changes that manifest as window effects. So, for instance, they can be alone. For instance, this is a patient. We know that the CSCR because of the changes in the RPE that manifest as window effects. And in the left eye, this is the fellow eye. The left eye, there's an acute leak. So there's an acute leak here that happens. The patient comes for this eye for the metamorphopsia that is he or she is, he most likely, is suffering from. But when you look at the other eye, you know that this patient has had previous attacks of CSCR with RPE disturbances. Now, these atrophic changes are often under the fovea because if somebody has pooling in the center and then sleeps on their back, sometimes the fluid goes into the fovea and kind of slowly depletes the RPE pigment from the fovea. So oftentimes you have the subfoveal RPE changes because of this shifting fluid, but the shifting fluid can also occur elsewhere. If you have a lot of fluid, the fluid tends, while people are awake and standing up or sitting up, the fluid tends to go down. You have these tracks of RPE changes, and on the fluorescein angiogram you can see what looks like a window effect with a track that fans inferiorly. Now, last thing, a neurosensory retinal detachment CSR can look exactly like an exudative RD due to inflammation or like a scleritis or a uveal infusion. So remember to keep CSCR in the differential diagnosis of exudative retinal detachments. Okay? How do you diagnose CSCR? Well, if you see a bleb and in a relatively young male, this is probably CSCR until proven otherwise, bleb of subretinal fluid. But if you're not sure, there are other ways of diagnosing it, and very importantly, the OCT. We just saw this earlier. The OCT is non-invasive and extremely useful. It will detect the neurosensory retinal detachment. It will detect the PED. In this case, the PED is next to the neurosensory retinal detachment. In here, the PED is under the neurosensory retinal detachment. So both combinations exist. It will also show you if the neurosensory retinal detachment is relatively young and acute, because the ellipsoid zone will be detached and it will not be elongated. But it will also show you in cases where there is chronicity, where the photoreceptor outer segment starts to elongate because they are no longer in contact with the RPE, and the RPE is unable to suck the discs from the photoreceptors and phagocytose them in a nice way. Therefore, these photoreceptor discs will stagnate and will elongate right here, and they will start to have a yellowish hue because of all the fluorophores that are accumulating in them. And if you do an autofluorescence, it will become a little hyper autofluorescence. So the OCT gives you a lot of information, whether this is acute or chronic, the location, of course, of the bleb and everything. And if you do an enhanced depth imaging OCT, you will see a much thicker choroid than what you expect. The other thing that you can use the OCT for is that you can use it to explain to the patient the follow-up. That if the patient comes in like this and they don't want to wait, you explain to the patient that it's probably a good idea to wait before going ahead and treating it acutely. And then the next time the patient comes in, you will see that the subretinal fluid disappears little by little. So this reassures the patient and reassures you. Now, autofluorescence is another way of detecting CSCR. If you don't want to do a fluorescein angiography, you can do just an autofluorescence. It's non-invasive. What you will see is at the level of the the spot that leaks, you will, if you have a good quality FAF, you'll see a hypoautofluorescence. This is a very, here it is. There's the spot. It's right there. Okay, it actually is a smokestack, and you can see here it corresponds to this hypoautofluorescent spot. And in the pool of subretinal fluid, you will see a little bit of hyperfluorescence because of what I mentioned earlier, the fact that the discs of the photoreceptors are not being phagocytosed, and therefore the fluorophores accumulate in the subretinal space. So it can look very much like, almost like a best autosomal dominant dystrophy. If you want to confirm for sure what it is it another leak to do something else, you definitely will need to do a fluorescein angiography. It will show you the leak, it will show you where it is, it will show you the pooling, okay, and it will eventually show you if there are, in certain cases, just pigment epithelial detachments or just RPE changes, as we saw earlier. Now, you can do an ICG. We don't usually need to do it, but in some cases you can do it, and it will show you the hyperpermeability of the choroid. It's diffuse and multifocal, hyperfluorescence of the choroid that exists, and it will also show you the pigment epithelial detachments in CSCR, which tend to have this configuration. The most important thing, if you're not sure, because sometimes polypoidal vasculopathy can masquerade as a CSCR, so the ICG is a good value. It will distinguish a CSCR with this hyperpermeability from a polypoidal vasculopathy, in which you will see the polyps and you'll see the branching networks. Okay? Clear enough so far? All right. So how does this CSCR behave? Well, it's generally it is self-limited. It resolves within 3 to 4 months in 90% of the cases, and the patients do gain the most of their vision back, but they will more or less always have some kind of complaint. They don't see, the colors as brightly as before. They may have decreasing contrast sensitivity. They may still have a grayish shadow where the bleb was, and sometimes night vision problems. You have to counsel them about that. Sometimes things don't resolve completely, and you get sequelae. You can get what we call retinal pigment epithelial scars. Such as here, these are RPE disturbances that we call them, the scars, and they don't leak on the fluorescein angiogram. They just look like, RPE atrophic changes. As we said earlier, you can get, persistent yellow spots, okay, under the retina, and you can get diffuse and progressive RPE changes from the chronic fluid. Now, the recurrences are common, okay, and most people get three. Those who recur, and will get 3 or more recurrences. And chronic CSR is one of those difficult things to treat, actually. Then the patient will have persistent neurosensory detachment, will continue to have a visual decline. They can get subretinal fibrosis. They can get CME, as I said earlier, but they can even get complicated with choroidal neovascularization. And in general, if you have a long-standing, I'm sorry, if you have a long-standing CSCR, then of course the visual prognosis is not as good. What is the differential diagnosis? You may all take off your phones, okay, and take a picture of this because you need to know that. Okay, that's going to come in exams. I'll give you a few seconds, and I'm not going to go over it because it's long. But suffice to say that infectious inflammatory diseases that ooze fluid can look like CSCR. Malignant hypertension, of course, because you get choriocapillaris ischemia, which disturbs the RPE pump function, and therefore you don't have that barrier function of the RPE that's intact anymore, and you can get fluid. AMD with polypoidal, vitelliform macular dystrophy, especially in cases of chronic CSCR that have the yellowish fluid. It can look like Best disease. Tumors, because tumors can also leak, all right? Optic nerve pit maculopathy with leakage coming from the optic nerve. The fluorescein and the OCT will definitely give you the diagnosis. It will show you not a hot spot in the retina, but it will show you, where the fluid is coming from the optic nerve itself. Retinoschisis, because retinoschisis can have sometimes not just the schitic changes and the cystic changes within the retina, but also under the retina. And in some cases, segmental retinitis pigmentosa, in cases where you have RPE changes in one area, and this is can confuse it with one of those epithelial tract that we've seen in chronic CSR. Okay, treatment. When do you treat? You treat if you have persistent fluid that more than 3 months. Okay. Now you may consider treating before 3 months if there are occupational needs. If the patient is really bothered and needs to see very good, or if there's an only seeing eye, you don't want to prolong and subretinal fluid under the fovea. If there's a history of loss of vision from CSR in the fellow eye, okay, or if you have a chronic CSCR, you might as well consider treating earlier. In one eye, consider treating earlier in this fellow eye before it becomes chronic as well. And there are several methods of treating. You can treat with focal laser treatment, and this is applicable to any focal leak that is safely away from the center of the fovea. So I would say within 1,000 microns, you can go ahead and do focal laser treatment. It works very, very well, very easy. You don't inject anything. You can do photodynamic therapy if you have leakages that are originating from the center of the fovea. You can do medical treatment and, of course, retinal counseling. So focal laser, this is something where you can do focal laser for, okay? This is away from the edge of the FAZ, so there's no problem in giving. This is not a central leak. This is an extrafoveal leak. You can give a focal laser treatment, very light treatment, just on the spot itself. A few spots, 3 or 4 spots, light treatment until you get the very, very light grayish thing. You just tickle the RPE, and the RPE just basically, revives and starts to pump the fluid out. So you're all set. Now, you can have complications, especially if the patient is on steady fixation. You may have a foveal burn, so you have to be very careful with your landmarks. Choose your patient, very carefully. Do not give any hot treatment because you can get a choroidal neovascular membrane. And of course, you have to use your judgment. If it's a little bit too close, you may not want to do it, thinking that the laser treatment may enlarge in the future. So use your judgment. But this is something where you can treat with focal. You don't have to give photodynamic therapy. Photodynamic therapy is going to be used when you have central leaks like this. This is too close to treat with focal treatment, okay? This will hasten the subretinal fluid absorption and will decrease the amount of recurrence because it causes an atrophy of the choroid. And because of the atrophy of the choroid, the chances of choroid becoming hyperpermeable and leaking again in that same area is less. However, because of the atrophy of the choroid, you may have vision loss as well. So it's not without consequences. In general, we like to do half fluence or half dose. We give half the dose of PDT, and we do it the standard way. Again, remember that it can cause choriocapillaris atrophy. Now, in cases where you don't have PDT and you cannot do focal, you may want to try something called aldosterone or eplerenone, which is an aldosterone inhibitor. It's a diuretic, and it inhibits the receptors of the aldosterone in the choroid, and that has been shown to decrease the permeability. Do not give acetazolamide. That is not proven to be of any benefit. You have to monitor kidney function and potassium and sodium levels if you give aldosterone or eplerenone, but know that only about 50% will respond to this treatment. It's important, these are young patients who are very bothered and afraid about their vision, so it's important to counsel them that this is something that can that will not lead to major visual loss. You want to give them hyperopic glasses to to help them out until the fluid disappears. You want to educate them about steroids and basically monitor them and then treat them when things become too long. Any questions? Any questions? Yes. If you have other signs such as like headache or auditory signs or flu-like illnesses before, or any tegumentary signs in the hair and skin, and if you suspect, it's a feel after all. In this case, what you would do, what you would do? What would you do? You will do an FA. What would you see? That's right. But those cases, and then you will have multifocal leakage. You can do an ICG as well. All right. Which will show you the the spotty hypofluorescences, and very important, you will have some hyperemia of the disc. Okay? Yes? It's almost always associated with the choroidal thickness, increased choroidal thickness. You don't have to have PED. You don't have to, but sometimes all what you see is a PED. Okay? Yeah. And sometimes those RPE changes could be the result of a previous PED or a result of a previous nodosensor retinal detachment. These are sequelae. And sometimes you don't even have the fluid, you just have the RPE changes. The RPE is sick. It manifests itself on the fluorescein. It manifests itself clinically if you look with hypopigmentation, okay? But it's not sick enough to completely disturb its function and give you a bona fide bleb. So all the spectrum is there. Anything else? Yes. How come it's bilateral? Because usually eyes behave the same way. Usually in medicine and in ophthalmology, you'll find that the eyes will behave symmetrically in general. It's practically almost always bilateral. Okay? The patient may manifest the first time in one eye, and the second time, it could be the same eye or not, and then with time you may get RPE changes in the other eye, or the patient has had the CSCR that wasn't seen and then comes in when manifests in one eye. But choroidal thickness is usually identical, more or less identical in the same eye, unless you have a myopic eye, as in anisometropia. Then yes, you will have it more in the hyperopic eye. But AMD, diabetic retinopathy, almost anything that you can think of will be bilateral. Yes, good question. Yes. No, it will be, because you're going to focus on the spot. You're going to use your angiogram. You're going to decide exactly where the leaking spot is. You're going to look very carefully. You're not going to shoot until you know exactly where you're shooting. And then you're going to aim at that. You put the aiming beam at that level. Focus it towards the back of the eye. Okay, focus it not on the retinal surface, but focus the beam towards the RPE and shoot, and you'll get a grayish response. Yes, it will be beneficial. Yes. Any other thing that I can answer quickly because we have to go on? Yes. You have to wait a few weeks. It will not start to give its effect immediately. You will need at least 3 to 4 weeks. And the thing is that if it works after like 1 or 2 months. It works, and if you stop it, then the things will recur. So it's a long-term treatment. You have to stop very progressively. All right, I must go on. Vitreoretinal interface abnormalities are the next stage. Sorry. There we go. A little bit of exercise for the knees. All right. So basically, in order to understand this, you have to understand the normal PVD, all right? And anybody of us, and all of us are going to get at one point in time some vitreous detachment as we age, okay? And it usually starts, as you know, remember the anatomy lecture? What is the strongest adhesion? Yes, music to my ear. And the next one? Disc. Okay, and the next one? Yes. Okay, good. All right. So PVD, when it happens, you start to get syneresis in the vitreous, and then the fluid starts to go out of a pocket through the vitreous cortex, and it will start to detach the vitreous bag, if you wish. And the cortex is going to detach from the retina in areas that have the least resistance. So it's going to detach first away from these areas that we talked about, okay? And then it will detach itself at one point from the fovea, because the fovea has less adhesion than the optic nerve, right? And so basically, at this point, you have just the perifoveal vitreous detachment, okay? And then you get the vitreous is detached from the fovea, so you get a vitreofoveal separation, but it's still attached to the optic nerve. And then here you get a near complete. At one point in time, the rest of the retina goes, the vitreous goes towards the center. You have too much fluid here. The cortex is floating in the middle. You still have the optic nerve adherent. And then when you have a complete PVD, it detaches itself from the optic nerve, but it still and will always remain attached to the vitreous space, because that is a very strong adhesion that doesn't go away. So if you have some difficulty of this vitreous leaving the fovea, you're going to get, vitreomacular abnormalities, interface abnormalities, starting with adhesion, which is basically this, okay? And when let's say that let's say that this doesn't want to detach, but it detaches here, okay? But this wants to stay longer, okay? This is what we call a vitreomacular adhesion. Or if it really, pulls on the fovea and it kind of lifts it, then we call them vitreomacular traction. And those can be symptomatic. Now, a vitreomacular adhesion, it's a perifoveal PVD, with normal retinal anatomy. On the OCT, there is no distortion of the retinal structure. It's beautiful, okay? It's non-pathologic. It's part of aging. It may take time for this vitreous to lift from the fovea, and it's asymptomatic. And it can be very tiny, just at the tip of the fovea, in the middle of the fovea, and it can also be broad, okay? It's not necessarily just on the foveola. It can be a little bit broad with a wider area. If this VMA continues and it causes, more traction, then you start to talk about VMT, vitreomacular traction, not adhesion. And this is pathologic because it's due to the persistence of the VMA, and it causes a disturbance in the macular architecture, and it's obviously symptomatic. Now, a focal VMA, right there, can just give you increased traction, but if you have, and this traction can give you splitting of the retinal tissue, giving you this foveal cyst, okay, which can unroof, giving you a lamellar hole, right? Or you can have a much broader vitreomacular traction. In this case, you don't have so much foveal deformation, but you make the whole macula starts to become, corrugated and lifted. All right. Now, how do you treat this? If you have a VMT, you can wait a beginning, okay, because a VMT can resolve by itself. Or if the patient becomes symptomatic, then you may want to interfere, and you interfere generally by doing the classic treatment is a pars plana vitrectomy. Okay, if you notice that the patient is symptomatic and the vision is starting to decrease, you do a vitrectomy, you remove the vitreous, and you cut this cortex away from the fovea. Okay, in general, when if it's not broad and you just have a focal adhesion, this responds very nicely to surgery. Now you can also use not vitrectomy, you can use an injection of something called ochriplasmin, which is an enzyme that's going to lyse the adhesions between the cortex of the vitreous and the retina. It's a proteolytic enzyme, okay, that will lyse the laminin and the fibronectin, and it will dissolve the matrix in between. It's going to cause a spontaneous separation of the vitreous from the macula. It only works about 50% of the time, and it's very expensive, and it's not controlled, and it can give you problems with color vision, problems with the ERG as well. So it's not exactly, and it's really, really expensive. So it's not exactly something that we like to use. I think it's going to fall out of favor very quickly. All right? So remember, if the patient is symptomatic, consider vitrectomy. Now, when you get the vitreous that starts to lift off the fovea, it can cause these little breaks in the foot plates of the Muller cells, the internal limiting membrane, and this will cause the Muller cells to start to produce, fibroglial tissue. Remember, the Muller cell is a glial cell. Remember, it's the big glial cell, so it has a potential to cause fibrosis. So when you get these fibrosis on top of the macula, the fibrotic membrane can start to shrink. And so we call these epiretinal, or more correctly, epimacular membranes, okay, which is actually a tissue healing response. And people have called it differently: cellophane maculopathy, surface-raining maculopathy, Rickley maculopathy, macular pucker, or what have you. All right, generally it's idiopathic. Most of the time, epiretinal membrane are due to a lengthy, difficult separation of the vitreous from the retina that causes this excitation of the Muller cells to, build membranes, all right? So it's usually due to an abnormal PVD after, abnormal vitreoretinal interface after a PVD, okay? And generally it happens in people who are older, who get the PVD, people, 50 years or more. And oftentimes it's also bilateral, but you can also have epimacular membranes that are not idiopathic, that are due to another pathology that happens. For instance, if you have a retinal detachment, is characterized by what? By PVR, right? PVR is a bigger, let me put it this way, epiretinal membranes, epimacular membranes are the form minima of PVR. Okay, it's a minimal PVR, all right? But you can, if you do laser or cryo, if you do retinopexy, you're going to stimulate an inflammation, and that inflammation is also going to give a tissue healing response on the surface of the macula. So any inflammation, retinal vein occlusions, very common. CRVO and BRVO give retinal membranes. Proliferative diabetic retinopathy as well, because there's also a proliferation and inflammation and trauma because of inflammation. And those membranes are going to cause wrinkling of the surface of the retina. Now, the epiretinal membrane can be non-contractile, okay, just cause a little bit of wrinkling, surface wrinkling. This is what we often call cellophane maculopathy, but it also can be contractile. And when it is contractile, it will cause distortion of the retina, and in this case, definitely you would like to do some, interfere and remove it. It will cause thickening of the retina, puckering. It will pull on the vessels in the macula. The pulling of the vessels is going to cause leakage. We saw a case not a long time ago, I think a week ago, in which there was a case of an epiretinal membrane, and the fluorescein showed leakage, and people didn't know why it was leaking. What was it leaking? Well, it was leaking just simply by traction. If you have an epiretinal membrane that pulls on the retina, it's going to get leaking. And those are going to cause a profound effect on vision, and they need to be removed. What do people suffer from? Well, they can complain of metamorphopsia, of diplopia, decreased vision. If you do a red-free exam, okay, you're examining with green light, you can see the epiretinal membranes outlines really, really nicely. If you do a fluorescein, as I said, you will see traction and you will see leakage. And if you do an OCT, the OCT will definitely show you the epiretinal membrane with the wrinkling and the distortion of the retina. It could be, like this, very thick, or it could be just more or less focal. So it'll give you an idea also about the health of the retina underneath, whether this is a healthy retina that if you remove the epiretinal membrane, will you still gain vision back? And in this case, yes, you will gain vision back because the outer retina is still very nice. Now, what is the natural course of an epimacular membrane? Is that the progressive contraction, tortuosity. You can also get cystoid macular edema. Sometimes you get the epimacular membrane that lifts spontaneously. It's very rare. What is the treatment? Surgical. Okay, so I'm not going to go too much into detail, just for the sake of time. You will indicate this every time that the membrane is symptomatic, and there is good potential. By OCT, you find that the retina underneath has relatively good potential. Patients will have less metamorphopsia, and most patients will improve their vision. Of course, there are always complications with vitrectomy, retinal breaks, retinal detachments, endophthalmitis, cataracts, of course, high pressure, glaucoma after surgery. All these are possible. And recurrence is possible, but very rare, like 3%. Questions? Clear? Good. Clear. Macular holes. Macular holes could be full thickness or lamellar, okay? A full thickness hole is a round break, okay, that involves all the layers of the neurosensory retina. Most of the time it's idiopathic. Again, it happens after a PVD, most of the time, or as a consequence of an ongoing PVD. the women are more affected than men, and often after the age of 60. Now, initially, Dr. Gass proposed that the macular hole is due to a tangential traction of the vitreous. And now, with OCT, we know that it's not just that the case. Some posterior traction of the vitreous onto the fovea can cause a macular hole. What's tangential traction? We know that the vitreous sleeps or sits on the surface of the retina, and you know that the fovea has a depression, right? The fovea is depressed, and the vitreous is, you know, attached to everything. And if the vitreous starts to pull not from posterior to anterior, but pulls sideways, what's going to happen, the first thing that's going to happen is that the fovea is going to flatten. Right? If it's put sideways, you will, instead of the foveal depression being like this, it's going to flatten, and then as it pulls, the vitreous pulls sideways even more, the fovea will have a little hole in the center, and then it will become round. Okay? So this is the original thesis of Donald Gass, Allah yarhamu. Basically, what you get then, you'll have a first thing, the first stage is stage 1A. It's not a full thickness hole yet. It's an impending hole in which there is traction of the vitreous, and all that xanthophyll, you know, the pigment that's in the inner retina, is going to accumulate. It's on the side of the fovea, but now that the fovea is pulled up, basically is going to accumulate in the middle, giving you an impression of a yellow spot. This yellow spot, little by little, is going to, you know, enlarge. It's going to move centrifugally to become a yellow ring because of the increased traction. And then at one point, within this yellow ring, you will start to kind of have a dehiscence, which is the stage 1B occult hole. You don't see it because you still have vitreous covering it, okay? That's stage 1B occult hole. And this occult hole, it's a hole, all right? But this occult hole will become manifest to a stage 2 hole, meaning a small hole in which the vitreous is starting now to lift itself, and you will start to see the this is an occult hole where the vitreous is attached, and then when the vitreous starts to move out, you can have a round dehiscence that you start to, you know, see clear clinically. Now, what can happen also is that the occult hole, the vitreous here, instead of moving upwards, it can rip, and if it rips, you will have a ripping. Like when you open a can of tuna, all right, a can opener technique, you will have a rip here, and slowly, this rip is going to, you know, complete itself, and you get an operculum, and then you see the hole underneath. Now, stage 2 hole is therefore a full thickness hole, okay? Stage 1B hole is a full thickness hole that you don't see because it's covered with vitreous. Stage 2 hole is a full thickness hole that is small, less than 400 microns. It is the perfect time to do vitreoretinal surgery because then, you know, the chances of its closure are very, very high, okay? Now, most of the time, stage 2 hole, you know, go on to become stage 3 holes. Stage 3 hole is when you have a bigger hole and the vitreous is detached from the hole. Okay, and stage 4 hole is when the vitreous is detached from the entire posterior pole, including the optic nerve. That's a stage 4. Okay, so now with recent OCTs, we know a little bit more about the development of a macular hole, and we know that there can also be caused by anteroposterior dynamic vitreomacular traction. Here, for instance, you have an anterior traction. Okay, we got an incomplete PVD, vitreomacular traction. This is going to pull. Okay, causing a pseudocyst, and this cyst can then rip, all right, in the middle, all right? I mean, this is not the same eye, but I'm just giving you an example of a mechanism, okay? That if you can have a rip right there, okay? This will become a lamellar hole in this case, and if it can also pull so much that you pull even the outer retina with it, as we can see here. All right, so you have a dehiscence here, a full thickness dehiscence in which the vitreous is still attached and the outer retina is pulled up, and then it gets pulled up even more and more and more, and as it gets pulled up, the hole enlarges. Okay, clear? Yes? I am hearing a doubtfulness. Okay, good. Okay, so as this happens, you can even pull a part of the inner retina with it, and the edges of the hole become a little bit everted. All right? So here is very nice. This was shown in ophthalmology in 2009. This was the first time that, you know, we talked about, this could not be just, you know, tangential traction, as Dr. Gass said, but it could also be anteroposterior. Let's go from here to here. You can see the vitreous adherent. Here it is adherent, and it's pulling. The retina is starting to rip. There's even pulling from there's so much pulling that even the cone the photoreceptors are getting off the RPE here. There's more pulling. Eventually, now you have a cyst and an outer retinal dehiscence, but you still have, some tissues there, and then the tissue itself rips itself, okay, and then here you go, it continues more, and then you get a can opener technique. This rips here, up, and then it becomes a full thickness, very obvious hole. And here's again maybe another way of showing it, where you have it starts with a cyst and then it rips. Now it's a full thickness hole within operculum. All right. What is this? I always talk about this. What is this? Yes, I love you guys. Okay, so macular hole evolution, well, they don't usually close unless they're very, very small, okay? So most of the time they will enlarge. And when they enlarge, what happens is that, the glial cells here migrate to the hole's edge and they start to contract. This is why you have this eversion, that almost looks like a snake's head here, all right? So, and you have a subretinal cuff because of that. Now, symptoms, most of the time people are not aware that they have a macular hole. It's, subhanAllah, it just, becomes very, very gradually. People are gradually aware that they're not seeing so well with their eye as before. If you do a fundus examination, you will see the hole, okay? And if you want to know clinically if this is a full thickness or not, we used to have our tricks before the advent of OCT to tell if there's this is a full thickness hole or not. But anyway, what you will see is the hole, generally very round. You may have RPE changes and lucky deposits in the center. You may have a cuff of subretinal fluid right there. You may also see a membrane. And sometimes you have I'm sorry, you may see an operculum, and sometimes you have an epiretinal membrane next to it, because, again, this is a vitreoretinal interface abnormality. If you want to play a little bit with the patient, you can put a very, very thin slit lamp beam in the through the hole and ask the patient if the patient sees the line continuous or not. And if the line is, the patient says no, there's an interruption in the center. This is what we call an Watzke-Allen sign, which tells you that there is a full thickness hole. Now, in a lamellar hole, the Watzke-Allen sign will be negative. You can also take the patient to the laser machine and put a very small aiming beam without laser, okay, but just the aiming beam at 50 microns and try to center it in the center of the hole and ask if the patient sees it. And if the patient doesn't see it, then that is a full thickness hole. This is a poor man's OCT, all right? But if you're lucky enough to have an OCT, then this OCT will show you the standard changes that will confirm whether it's full thickness. It will tell you, the status of the retina, the cystic changes, and everything, and it will identify whether the PVD is complete or not complete. You can do a fluorescein angiogram. It's not necessary. If you do it, you will see a little bit of hyperfluorescence in the center because there's less tissue. And you may, at the cuff, see a little bit of hypofluorescence because the RPE, because the cuff is basically like vertical, so the line the light that shines at it is not going to let you how do I say this? The retina is a kind of elevated, and therefore it basically blocks the visibility of the photoreceptors and the RPE in the choroidal background in that area. But we don't really need to do that. Now, lamellar macular holes are a form of macular hole, but not full thickness, in which they're inner macular hole. There's no subretinal cuff. There are cystic changes, yes. The Watzke-Allen will be negative, and there are no outer retinal tissue dissolution. The OCT will show it. And it rarely progresses to a full thickness. It can, but it rarely does. And an outer lamellar hole is when you have the hole in the outer retina and not in the inner retina. And the OCT will also determine this. And this is very common in optic pit maculopathy and in solar maculopathy. Okay, if somebody gazes at an eclipse or at the sun or even with a laser pointer, what happens is you get a disruption of the outer retina. Now, pseudo-macular hole is different. Is you have no loss of tissue. What you have is an epiretinal membrane, okay, that is kind of pulling centripetally towards the center, and you get this deep depression of the fovea that looks like a hole, but it's not. But you see that it's intact. Okay, the outer retina is intact, the inner retina intact, and that's a pseudo-macular hole. And usually, people don't see anything. It's asymptomatic. You can also get pseudo-macular hole when you have RPE atrophy, it looks like a macular hole, but it isn't. It's just an RPE atrophy. And in juxtafoveal telangiectasia, which I'm going to talk about in a moment, you can have an outer retinal holes or even inner retinal holes that can look like a hole. All right. Now, this is what is a lamellar hole. Okay, it's an inner defect with an outer preservation. This is again a pseudo hole. All right. You can even call it this a lamellar hole formation. This is a definitely pseudo hole, and this is epiretinal membrane that's pulling, causing a pseudo hole, but there is some loss of tissue in the middle here, so you will call this a lamellar hole. Natural course, as I said, most of the macular holes will progress unless you do surgery. The best time to do surgery is stage 2 holes, but stage 3, of course, you do it. Stage 4, yes, you do it. And then when the hole becomes large, then you have to use not just a vitrectomy, you may have to use like you can get the ILM to peel and shove it inside the hole to create a matrix so that the hole closes. You know, they do close, which is good. A lot of patients with macular holes tend to develop macular holes in the fellow eye. And the ones where there is a full thickness macular hole and no PVD, those are the people who are at the highest risk of developing a macular hole in the other eye. All right, take your phones. And these are the other causes of macular holes that you should need to know. So not just idiopathic. A few seconds. Trauma is a very big one, but this is obviously very known. A blue laser, okay? Laser photocoagulation, and all these things can give you macular holes. Even RP. How are we doing? Oh, I have to rush. Okay. So traumatic macular holes, they tend to be larger and they tend to be not so regular, and they tend to be also associated with more or less RPE changes and conclusive changes and other changes like dialysis or angular recessions, things that can happen with acute contusions. Okay, and the treatment, you can treat them with vitrectomy, but the prognosis will depend on the associated retinal findings. If there's a lot of conclusive changes and sequela of commotio, then the vision may not be as good as you would like. All right, pathologic myopia very commonly gives macular holes, which can be very difficult to detect. This is one of the beautiful things about an OCT is that you can see them. They're difficult to detect because the contrast with the RPE atrophy and the choroidal hypopigmentation does not let you see them very well. It can happen either because of macular thinning or because of the tangential traction that we talked about or because of an acute PVD. And they may, these are different, a little bit different than the idiopathic ones in that they can also be associated with retinal detachment. So what is the treatment, the current treatment for impending hole? You don't do anything, you just watch, okay, carefully, because they can abort. In 60% of the cases, the PVD just happens and the retina goes back into place, and the fovea, is never really, completely open, so it will go back and no big deal. But if you have a stage any 2 to 4 macular holes, you will need to do a vitrectomy. You will peel the you will peel the vitreous, peel the cortex, and more and more people are doing also a peeling of the internal limiting membrane. And if the hole is big, you may want to flap, bring the epiretinal membrane into the bed of the hole to cover the hole so that you create a matrix for the hole to close. You put gas in the eye, you don't put laser, and the patient is prone for about a week, 5 days to a week, sitting face down so that the gas can push on the macula until the healing takes place. Anatomic results are very, very good. Macular holes close in like 90% of the time, if not more. If you don't have successful closure, you can go in again, which is what we more often do, but sometimes the hole just enlarges and you get decreased vision. Complications of macular hole surgery are complications of any vitrectomy, okay? RPE alterations, retinal tears and retinal detachments, endophthalmitis, glaucoma, CME, cataract, all these, you list them every time that you talk about a vitrectomy. So nuclear sclerosis is common. People who have macular hole surgery tend to have cataracts more quickly. Late reopening of the hole can happen, and this is why we follow the patients. All right, any questions? No? Tired? Tired? No? Okay. Macular edema. Check your phones. This is the condition associated with macular edema. There are many, so there's, of course, no way that I'm going to be covering all this, but I'm going to be talking only about the post-surgical macular edema, what we call the Irvine-Goss syndrome. Okay? All right, so post-surgical macular edema was also described initially by Donald Goss after cataract surgery, which is a common cause for, a surgery that went beautifully, but then, in the weeks after surgery, patients don't see that so well, and that is because they have cystoid macular edema, all right? And it's usually associated with a little bit of a degree of inflammation in the back of the eye with increased permeability of the perifoveal capillaries. So patients will have decreased vision. They have beautiful surgery the first days, first weeks, and then they don't see so well, and you may have a low-grade inflammation in the eye. By microscopy, you will see a CME. You'll see the classic CME with the cysts in the fovea. If you do an OCT, you will see the cysts in the inner retina, and sometimes it's associated even with subretinal fluid. The FA is absolutely diagnostic. We saw one case yesterday. What happens is you've got an increased visibility of the perifoveal capillary network, an increased visibility of the epipapillary capillary network, and with time you get more and more leakage, and the leakage goes into the outer plexiform layer in the Henle layer, and it pools in there, giving you this classic petaloid appearance, okay, with a hot disc towards the end. This is practically classic for a CME. Usually it's self-limited. You give patients anti-inflammatory drugs and sometimes a topical steroid, sometimes an injection of steroids. Sometimes they don't. The CME does not resolve by itself, and in this case it can create a full thickness cyst or a lamellar hole, and sometimes RPE mottling. How do you treat it? The first thing you do is you look for a cause, okay? You don't just go ahead and give, ocular drops and, an injection of steroids. No, you look for a cause. You make sure that there is nothing that is creating this low-grade inflammation. There is no vitreous wick, for instance, going into the wound. There is no iris chafing between the IOL and the iris and so on. So you have to look for these causes that cause the low-grade inflammation. And you treat them, okay? You may do vitreolysis, you may take the patient back to surgery. It depends, and you can probably do most of the things with YAG. But then you can give, a stepwise approach. You can give topical steroids and non-steroidal anti-inflammatory. If that doesn't work, then you can give subtenon injections. And you can, administer a little bit of Diamox. Even, topically, that may work, all right? Anti-VEGF may work. It doesn't always work. Even steroids, I did a study a long time ago in which we injected triamcinolone in the eye. The first time it works well. If it's a chronic disease and you inject the second time, the result after the second or third injection aren't as good. So sometimes, a subtenon injection may be just as good. And if nothing works, okay, then you may want to consider doing a PPV and removing the vitreous, removing any inflammatory cytokines in the vitreous, and removing the hyaloid from the surface of the retina. And then you give some intravitreal steroids and you pray, okay? So that's how you do it. Any questions? Okay, we have 10 minutes and we're going to go to the juxtafoveal telangiectasia. Right. So juxtafoveal telangiectasia is a very huge subject, okay? But if you want a good review, we've done an article here that was in 2010 in Miaggio. It's free online. You can have it. It's basically, review of all the cases of juxtafoveal telangiectasia, the subtypes, the classification, and all the treatment modalities. So I really urge you to read this because it's like a textbook, okay? Now, idiopathic juxtafoveolar retinal telangiectasis is the correct term that was proposed by Goss, okay? And people are calling it now parafoveal telangiectasia or parafoveal telangiectasis or MACTEL or idiopathic macular telangiectasia, but this is the original term that you should know. And Goss described three groups. Described the group 1, which is usually unilateral, okay? And where you see the telangiectasis. You can clinically see. It almost looks like a diabetic retinopathy that's limited to the foveal area, okay? The group 2, you don't see the telangiectasis clinically, but you can detect them if you have a high index of suspicion and if you do a fluorescein angiogram. And the group 3 is very, very rare. I have one case, and there have been like a handful of cases prescribed in the literature. I'll tell you a little bit about it, okay? They are different in appearance, in pathogenesis, and management. Let's look at group 1, type 1. Type 1 is what Januzzi a few years ago called aneurysmal telangiectasia. There are capillaries next to the fovea that look like microaneurysms, okay? And therefore, he called this aneurysmal telangiectasia. You can see them when you do a biomicroscopy. It is congenital, Okay, it's a congenital problem. It's unilateral in 97% of cases and usually affects males. Usually the people start to complain not when they're 20 or 30, but when they're in the 40 years old. That's when they start noticing that they have disturbances in vision. It causes a mild visual blur, maybe 20/30, maybe 20/40, a mild visual blur. It's really never very significant. Okay. What you see, how do you diagnose it? Is you can see the telangiectasis clinically. All right. So easily visible telangiectasis and aneurysmal dilations, usually straddling the temporal foveal raphe. If you draw a line, usually you've got telangiectasia above and below the horizontal line, usually temporally. It can be nasal, but usually it's temporal. Usually they're about for a surface that is no more than 2 disc areas next to the fovea, and it is associated with exudation, therefore macular fluid and lipid. And you can see the fluid on the OCT. And if you do a fluorescein, it will actually leak. You can see that. If you do an ultra-high resolution OCT, which is available in research facilities, you will see the parafoveal intraretinal microvascular abnormalities, okay? The retina elsewhere is usually uninvolved. So we can call this like a Leber, it's been called Leber-miliary aneurysms or a mini Coates disease, like Coates. Males, unilateral, aneurysms. So a mini Coates disease. The visual acuity is excellent for many, many years. It can deteriorate later in life, and the vision loss happens because of because of macular edema, okay? Just like any macular edema, all right? And the treatment is indicated if it's not going to cause more decreased vision. The way that Gauss used to treat it is by doing very, very gentle laser photocoagulation, because that's what was available in the 60s and the 70s. We didn't have these other methodologies. So laser, a little bit of laser to the aneurysms that are causing the most leakage, that may get the leakage down. Most of us nowadays will not be doing laser to this area. It's too close, okay? Because you can actually create scotomas and enlargement of the laser spot and create more vision loss than if you left it naturally. So there are other ways of treating it, perhaps with anti-VEGF. It's questionable. It may work. Okay. The differential diagnosis is the differential diagnosis of anything that can give you microvascular abnormalities in the retina. So diabetes has to be number 1, BRVO, CRVO, sickling retinopathy, radiation retinopathy, but anything else, ocular ischemic syndrome, Coates disease, hypertensive retinopathy, anything that gives you microvascular abnormalities has to be put in the differential diagnosis of this type 1 juxtafoveolar telangiectasia. Treatment, as I said, laser photocoagulation to decrease the exudation. You can inject steroids. The effect is usually transitory, okay? And anti-VEGF, more research is needed to determine the benefits. Type 2 is what you guys are going to see most and what you guys are going to miss the most. And I'm going to insist a little bit on this. Now, recently, we called it just MECTEL or MECTEL 2, okay? And Lawrence Yanuzzi decided, instead of calling it, idiopathic juxtafoveolar telangiectasia type 2, decided to call it perifoveal telangiectasia, in contrast to aneurysmal telangiectasia. It's the most common. It is acquired. It's not congenital. And it often happens in people who are above the age of 50. Males and females are affected equally. All the patients I have seen have been female for some reason, but it's, apparently it occurs also in males. It's bilateral, but it may be asymmetric. And the telangiectasia is barely visible, okay? You can have subretinal neovascularization in this, and the vision loss is not due to edema. The vision loss is due of progressive loss and atrophy of the retina, okay, of the outer retina. The stages. Stage 1 is barely visible. That is what stage 1 is. Barely visible, a little bit of opacification of the temporal part of the fovea, sometimes even the nasal part of the foveola, but that's all what you see. You will not see capillary dilation. And if you do a fluorescein angiogram, that's all what you see. A little bit of staining. You can't really tell if it's leaking or not, okay? And you can't really tell where the juxtafoveal where the telangiectasis is. You only see a little bit of staining, okay? Stage 2 is when it becomes a little more obvious. You have perifoveal graying, okay? Perifoveal graying. And if you do a nice OCT in a patient who has good media, you may be able to see an enhanced visibility of the capillary network around the fovea, all right? Centrally, This is thin. There's no edema. And because it's thin and because everywhere else is a little bit opacified, it can be mistaken for a macular hole. All right, so it is in the differential of a macular hole. All right, so what you will see is again staining of the capillaries at the end of the fluorescein angiogram. Stage 3 is when you have right-angled venules. The veins are going to come towards the telangiectasia. Okay, they're going to curve towards the intraretinal telangiectasia that you don't see very clearly, and you will start to have some channels there that Januzzi has described. So stage 3 is the right-angled venule stage. And here you definitely start to see the telangiectasia on the fluorescein a little bit more, but not clinically. And you will see the right-angled veins, all right, going into there, and a little bit staining towards the end. You may, at this point, see intraretinal crystals. These are very, very characteristic, but they're not pathognomonic, but they're very characteristic. Stage 4 is when you start to see pigmentation. Okay, where the right angle vein comes towards the telangiectasia, you will have some pigmentary deposits, because what happens is that the RPE doesn't like the telangiectasia. Okay, the RPE is going to start to grow from where it is towards the retina to eat up, okay, phagocytose the telangiectatic vessels. And when it does that, it leaves pigment. But when it does that, it also leaves a channel where the RPE grows, is a conduct. And it's a conduct later for the telangiectasia to grow under the retina, okay, giving you choroidal neovascularization, and for the RPE to go into the retina. All right? So this is how subretinal neovascularization develops. But before it develops, what you get is the RPE that comes into the area of the telangiectasia, usually where the right-angled venules are, and giving you these, black pigmented spots. Okay, this is very characteristic. Sometimes all what you see is a black spot. You really don't even see the opacification of the retina around it, but you do a fluorescein, you see, this is not normal. You see, hyper visibility of the capillary network and staining and some leakage at the end. Here's one of my patients, and you can see the progression from the stage 2, where there was opacification, to the right angle venule and the stage 4, and here's even more stage 4. Okay, this is the same patient over the years. This is another patient, right angle venules, a few crystals. Okay, it looks almost like a macular hole because of the opacification here. And then slowly pigment starts to develop, and later on even more pigmentation. This is stage 4. All right. And here's another patient of mine with pigment on both sides and crystals on both sides. Beautiful picture. Here's one patient, a VIP patient, who basically all what she had was pigmentation temporal to the fovea in the right eye and in the left eye. Another one, pigmentation here. I'm sorry, this is the same person. This one here, this was early on, and then pigmentation increased, and this one was many years ago, and this pigmentation increased. So when you see a little spot of pigment next to the fovea, remember, MACTEL2. Now, OCT will show you no retinal edema. There's no leakage. On the contrary, you will have loss of tissue, loss of the outer retina, and cystic spaces inside the retina. And the ILM, where the cystic spaces are and there's loss of tissue, the ILM continues intact. So this sign we call the ILM drape, okay? And the vision loss is because of the loss of tissue. If you do fundus autofluorescence, you will see, this is a normal fundus autofluorescence. The center of the macula has to be dark, okay? And it's dark because the cones have less lipofuscin inside them. Yeah, I'm done. And you also have the xanthophyll that blocks the out of the light of the autofluorescence, and you have the RPE that has more